Hello, everyone. Welcome to today's webinar. I'm going to give a little second for everybody to get in and prepare themselves for an excellent webinar today. All right, it is 12:02, so today's webinar is going to be great. I am Jonathan Dinkins, your webinar facilitator. If you have any technical difficulties, I can be reached at Q as in quiet, Z as in zebra, V as in Victor, the number 3 at cdc.gov. The chat is disabled, so if you have any questions or comments, please use the Q&A box. And now I am going to pass it over to our host. Enjoy.
Hi there, my name is Katie Riley from the Massachusetts Department of Public Health. On behalf of myself and my colleague, Melissa Cumming, who's an epidemiologist on the HAI-AR team, we'd like to welcome Massachusetts facilities. I will turn it over to Jamie from Maryland.
Thanks, Katie, and thank you to everyone for joining, and thank you and good afternoon. I am Jamie Rubin, I'm Infection Prevention and Control Program Administrator here at the Maryland Department of Health. So on behalf of all of my colleagues here at MDH, we also wanted to extend a special welcome to our Maryland facilities and partners and remind the team that our team here at MDH is always standing by to assist with questions or implementation support. So please don't hesitate to reach out if we can help in any way. Welcome to all of you again, and I'm going to hand things over now to Shayna in Virginia.
Thanks, Jamie. My name is Shayna Bernard, and I am the Antimicrobial Resistance Coordinator at the Virginia Department of Health, and we would like to welcome all of the Virginia healthcare personnel in attendance today. I would now like to introduce our speaker. Dr. Janet Glowitz is a senior infection preventionist with the Division of Healthcare Quality. She holds a master's in public health epidemiology from the Health Science Center at University of North Texas and a PhD in nursing from the University of Texas at Arlington. Janet has practiced infection prevention both as a nurse epidemiologist in public health, acute and outpatient settings. She currently assists with outbreak investigations in healthcare settings and serves as a subject matter expert for hand hygiene in healthcare settings. Dr. Glowitz is the immediate past president of the Certification Board in Infection Control and Epidemiology. Thank you, Dr. Glowitz, for speaking with us today, and I will pass it over to you now.
Good afternoon. I'm so happy to be here, and I'm so happy to see attendees from across the Eastern Coast interested in hand hygiene, and just really happy to have you here and to talk about the role of hand hygiene in limiting the spread of multi-drug resistant organisms. And I just want to apologize up front. My computer is a little wonky. I'm using my mouse to change one screen and my keyboard to change another. So if things get off, I'm going to do my best. If you might see me making funny faces on the screen or something. But I'm really super happy to be here talking about hand hygiene. I have no disclosures. And you've seen the objectives. So we're just going to spend a little time talking about MDROs and the ways that they are transmitted in healthcare facilities, ways that healthcare personnel may be involved in that transmission. And we're going to identify infection prevention and control practices, namely hand hygiene, and ways to implement that at the healthcare facility. Elements of hand hygiene programs that are needed to help healthcare personnel adhere to hand hygiene. So as you all know, hand hygiene is the foundation of infection prevention with a long history involving some of the greatest healthcare heroes. Even before germ theory was widely accepted, Oliver Wendell Holmes and Ignaz Semmelweis, working on different continents without an internet or an iPhone, were both convinced that contagious material on the hands of healthcare personnel were the cause of the spread of childbed fever. We've come a long way since we used chlorinated lime water to disinfect hands, but we still can't see the bacteria, and we may fail to recognize just how quickly and easily our hands become contaminated. There. So even brief interactions with the healthcare setting can lead to contamination of the hands of healthcare personnel. And in a study evaluating transmission risk, looking at Acinetobacter-Baumannii, patient-level factors were not associated with transmission, but care activities were. So when comparing the hands of healthcare personnel upon entry to the room to contamination levels when they came out of the room, it was noted that their hands were twice as likely to be contaminated if they had touched the bed rail, 5 times as likely to be contaminated if they had interacted with the ET tube, and more than 8 times as likely to be contaminated if they had performed a wound or dressing change. So just showing that hand contamination happens very quickly after very brief interactions with the patient environment. We know that hand hygiene is a high impact intervention. Modeling studies show that improvements in hand hygiene may reduce transmission more rapidly than improvements in environmental cleaning, particularly when a drug-resistant organism is involved. I'm trying to move something on my screen to there on the screen you're not seeing, sorry. This was demonstrated at the University of North Carolina Medical Center, where hand hygiene was high. They were at 80%, and they increased their hand hygiene to 95%. They did a really innovative outreach. They actually have the collection of hand hygiene observations in all employee evaluations. So every employee at the facility is required to conduct a certain number of hand hygiene observations each month. And regardless of whether or not that is accurate data, their infection preventionist feels like that indicates that every employee has at least thought about hand hygiene and perhaps even discussed hand hygiene with a colleague during the month. Their hand hygiene increased to 95%, and they saw 197 fewer healthcare associated infections, 22 fewer deaths, and a $5 million savings over a 17-month period. So how are we doing? We always want to know how are we doing. And when you look at the literature, mainly what you're going to see are studies that are from places where they know they have a problem and they're trying to improve. And so we don't have publicly reported hand hygiene data for good reasons in the United States. It's really hard to gauge how we're doing. We also do not have a standardized method of collecting hand hygiene data. So again, it's just really hard to know how we're doing. In Canada, a point prevalence study was done using the WHO My 5 Moments, and they saw that nurses performed hand hygiene a little more than 80% of the time. So that's pretty good. When they calculated the adherence rate for physicians, they found that physicians performed hand hygiene about 45% of the time, a little more than 40%. But in another study in the United States, actually in Maryland, they looked at a trauma resuscitation area, and they reported a 7% overall adherence rate with no hand hygiene prior to clean procedures, unless you considered direct donning of gloves to be adherence. And direct donning of gloves means that they were donning their gloves without performing hand hygiene prior to putting the gloves on. If you considered that to be adherent, then their adherence rate rose to 57% overall. And so that just tells us that explicit expectations and what is considered adherent and what is considered non-adherent are very important when working with healthcare personnel. So there are some practices that are considered essential for hand hygiene programs. Previously, the SHE compendium referred to these as basic practices, but we will be considering them to be essential practices. And those include maintenance of healthy hand, skin, and nails, use of appropriate products, accessibility of supplies, use of appropriate glove use, reducing contamination associated with sinks and sink drains, monitoring adherence, and providing timely and meaningful feedback. So I actually had a tab where I could provide polls, and I am not seeing that tab. So I do want to pause for a second and just ask a question. I'll have you just raise your hands. Oh, I do see the poll. I hope that you see it. Have you had irritated hand skin during the previous year? So just thinking back over the course of the last year, have you had any problems with your hand skin? If you cannot see the poll, then you can raise your hand or give us a thumbs up and let us know. And I'm going to confess, I can't see all the participants. I only see the panelists.
Yeah, the second box is empty, everyone. But we'll answer the first box. And I'm going to go ahead and end the poll very shortly, Janet.
Thank you.
Yeah.
And then the second question, what do you think is a common cause of hand skin irritation? You can enter that in your Q&A box. I just wanted you to think for a second about what do you think is most irritating to your hands? And Elizabeth, I'll let you.
Yeah.
We're ready.
All right, we're at about 100 participants. I'm going to go ahead and end the poll and share the results. Janet, can you see the results?
Yes, I see that about 56% of people have had irritated hand skin during the previous year. And congratulations to the 44% of you who did not. That's fantastic. And that's pretty consistent with what's in the literature regarding irritated hand skin. I did not see a lot of literature about seasonality, but we're going to hit some issues about irritated hand skin. But you do reflect what we see in the literature as far as numbers of people, numbers of healthcare workers with irritated hand skin. So the first essential practice is to promote healthy hands. And so we just want to define what healthy hands are. These are hands that are free from pathogens. They have intact skin, no redness, itching, or cracking, with short natural nails that are no longer than the fingertip and are maintained according to facility policy. And so there is room for variation as far as what facilities allow and where people work related to the maintenance of fingernails. But some common causes of hand skin irritation are frequent hand washing or immersing hands in water. So many healthcare personnel believe that alcohol-based hand rub is irritating to their hands. But in fact, there's much more evidence that exposure to water, wearing gloves, and using antiseptics can result in irritant or allergic dermatitis. Most healthcare personnel don't realize that our work is classified as wet work. And wet work is defined as washing your hands more than 20 times in a shift, or immersing your hands in water for more than 20 minutes, or wearing gloves for more than 20 minutes per day. And in a survey of over 1,000 United Kingdom nurses, 70% reported using chlorhexidine gluconate more than 20 times per shift. Some nurses described allergic responses to chlorhexidine, leading to some speculation in the literature that there may be the opportunity for healthcare personnel to become sensitized to it. Symptoms that they reported included dry skin and systemic responses like wheezing or coughing. These were common. Again, fragrances and soaps, sanitizers, and lotions are common allergens. Soaps are known for their ability to dissolve lipids. And when hands are frequently exposed to soap and water, the lipids within the surface of the skin can be stripped away, leaving the hands dry and cracked. Occlusive gloves are indicated according to standard and transmission-based precautions whenever there's potential exposure to infectious materials. They should be worn when hands will have prolonged contact with water. But they also may increase maceration of the hand skin, particularly if your hands are wet when gloves are put on. So we need to really make sure that our hands are dry before we don gloves, and we need to pay attention to how long we keep them on. Trying to carefully change my screen. So irritant dermatitis begins usually on the back of the hands or in the skin folds. Healthcare workers will often say that their hands feel tight or dry when they make a fist. They may notice cracking. And because the lipids have been removed from the skin by hand washing, there's almost like a pathway right to very sensitive nerve endings in the skin, and that can cause it to sting when alcohol-based hand sanitizer is applied. This is especially associated with a history of atopy, again, that increased hand washing and increased use of gloves. Allergic dermatitis can affect all areas of the hands. I've had someone just anecdotally tell me that when you see a rash on the palmar surface of the hands, you almost always can know that that's an allergic response. And I really just want to point out that there are numerous potential allergens, including rubber accelerators, which are used in nitrile glove manufacture, surfactants in soaps. And again, I want to point out that CHG sensitization can be an issue for some, or could potentially be an issue for some healthcare workers. Sorry. When allergies are being assessed, occupational health may need to refer folks to an allergist, and patch testing may be required to identify what the person is actually allergic to. So to keep hands healthy, we do recommend the preferential use of alcohol-based hand sanitizer in most clinical situations. And this is to reduce the exposure of the hands to water. Wearing gloves according to standard and contact or other transmission-based precautions when they are indicated, monitoring the duration of the glove wear, and using facility-approved moisturizers regularly. For some healthcare personnel, applying hand moisturizer when they come on work, when they take lunch break, and at the end of the day can be very helpful just to get it into a routine. And then seeking consultation if redness, cracking, or irritation occurs. Occupational health departments should have a plan to provide cotton undergloves if people have hands that are cracked or irritated. Those cotton undergloves can help absorb moisture. If they are used, they should be changed whenever gloves are changed, and only sterile cotton undergloves should be used under sterile gloves whenever an invasive procedure is being performed. So when, where, and how to clean hands. Another poll question, Elizabeth, if you have it, it's kind of an opinion. Do you agree with the statement? Let's see if, or I am very satisfied with hand hygiene products at our facility. Agree or disagree? And you are answering confidentially, I would say. Ooh, 90% of you agree. That's fantastic. I'm happy to see that. It is really important that healthcare personnel have input into the products that are used at their facility and that they like those products. You're not likely to use a product that you don't like. And during the pandemic, we saw so many problems with changing products. And if you were needed to use any locally produced alcohol-based hand sanitizer, you might have noticed just a terrible odor associated with it, really liquid feel to it. It was not a pleasant product to use. It's important that healthcare personnel like the product that they're being asked to use. I also just want to go over for just a second how alcohol-based hand sanitizer and how soap and water work. So of course we use them to reduce the numbers of bacteria on the hands, and they do work differently. Alcohol-based hand sanitizer denatures the proteins of organisms. This is important because it destroys mechanisms that bacteria might use to resist antibiotics. So you may occasionally see studies that talk about increased tolerance to alcohol. When they do that, they're really attempting that's to kind of grow the organism in the alcohol. There was another study that was published in AGIC that looked at the MICs, the minimum inhibitory concentration of alcohol against vancomycin resistant enterococcus. That is not really relevant. In that study, they did show that at about 20% alcohol, the bacteria were tolerant of alcohol, but alcohol-based hand sanitizers have 70, 60% or above, usually, 70% alcohol-based or alcohol in the formulation. There are non-alcohol-based hand sanitizers that are available on the consumer market and actually are approved by the FDA. But non-alcohol-based hand sanitizers do rely on entry into the organism and can be resisted through their efflux pumps. And so for this reason, we recommend only alcohol-based hand sanitizers. Soap and water surrounds the organisms. If the organism has a lipid envelope, it may disrupt that lipid envelope and it may kill the organism before it is rinsed off with soap and water. I also want to point out that alcohol-based hand sanitizers and antimicrobial hand soaps are regulated by the Food and Drug Administration as over-the-counter drugs. And this is important. This is probably the only drug in your facility that might be restocked by the Environmental Services Department, depending on who your facility has do that. But disinfectants can make claims about exactly which bacteria they kill. Alcohol-based hand sanitizers and soap and water are not allowed to make those claims. We do know that alcohol-based hand sanitizer has broad antimicrobial activity, but manufacturers are not allowed to make a specific claim about organisms that are killed. When to clean your hands, WHO has had the 5 moments for hand hygiene for quite some time. In 2017, CDC released the core practices for safe healthcare delivery in all healthcare settings. And we added we aligned our moments for hand hygiene with WHO and added 2 additional moments, which include moving from a soiled to a clean task on the same patient and immediately after removing gloves. How much hand sanitizer? Where should hand sanitizer be located? In 2013, Chan did a study showing that a minimum level of accessible hand sanitizer would be to locate one outside the patient room in the hallway and at a minimum one dispenser inside the patient room. And in fact, lack of access to hand hygiene supplies is often noted as a significant barrier to performing hand hygiene. In multi-patient rooms, suites, or bays, you may consider one dispenser for every 2 beds to be a minimum threshold for accessibility. Repeated studies have shown that the dispensers need to be unambiguous. So you don't have to figure out, is it a hand sanitizer dispenser? Is it a lotion dispenser? Is it soap? Needs to be visible and in the workflow of healthcare personnel. This slide just again, looking at how much alcohol-based hand rub is allowed. 10 gallons is allowed in a single smoke compartment. 1 dispenser per room off corridors. So 1 dispenser in the patient room is not included in that calculation. And a smoke corridor is often identified as a hallway. There's usually automatic doors at each end of the corridor that close. And that's how you can, I mean, your building manager will know what the smoke corridors are, but when you're walking through a facility, you can easily identify them because they have automatic closing doors at each end of the smoke corridor. So 10 gallons in each of those. And then another thing I want to point out is that the National Fire Protection Association, who really writes the life safety code for the Joint Commission, they do require that the dispenser be tested every time it is refilled. And so of course that, you know, malfunctioning dispensers can be a slip, trip, or fall hazard in hallways. We also want to make sure that it's dispensing the correct amount and checking them is make sure that they don't dispense in a, you know, in a funky manner so that they're working as intended. Technique matters. So areas of the hands that are frequently missed include the fingertips and the thumbs. WHO has a very prescriptive 6-step method. Several studies have found that personnel do not adhere to multiple steps when they're performing routine hand hygiene. So the most important message should be that all surfaces of the hands should be covered with hand sanitizer and should be rubbed. Even though they may not follow each step, instructing them in a simplified structured technique like the WHO 3-step method, which is shown in the slide, the surfaces of the hands, the fingertips, and the thumbs, can help them build muscle memory and a habit of good technique. And a good way to teach this can be to apply glow gel to all surfaces of the hand, then use the UV light to show that, you know, all surfaces are appropriately covered, and then have healthcare personnel wash their hands, again, using the UV light to see that they've removed all of the glow gel that was applied. Again, most wall-mounted dispensers will dispense about 1 milliliter of hand sanitizer, and sometimes the amount dispensed is an important healthcare personnel satisfaction measure. Sometimes healthcare personnel are less satisfied when they get a large amount of hand sanitizer with each activation, but it's really important to cover all surfaces of the hands and that the hands stay wet for at least 15 seconds. It may take 4 to 6 milliliters to cover larger hands, and so employees with large hands should be taught to activate the dispenser more than once, and certainly personnel should take a full activation each time that they use hand sanitizer. Again, it's, you know, remind healthcare personnel that alcohol-based hand sanitizer is an over-the-counter drug, and you don't want to take half a Tylenol. You want the full dose. Supplies for hand washing are pretty straightforward. We'll talk more about these in a second, but plain or antimicrobial soap should be available throughout the hospital. Disposable towels, warm, not hot running water. Even though sinks are constructed according to building code, we still want them to be visible. And studies have shown that when the sink is visible from an occupied bed, healthcare personnel spend more time washing their hands than when the sink is not visible. And if possible, dedicating sinks to hand washing. We'll talk more about why we would want to do that in just a moment. So glove use, another poll question before we move on. True or false, gloves should never be worn during patient transfer. So essentially outside of the room, outside of the patient care area. While you're answering that, I just want to mention that I can see there are 59 comments in the chat, but I'm hesitant to open that up, but I want you to know that we'll get to those.
And I also want to note that I and just a couple other people, they're hearing some background noise, but it's not everybody.
So if you're not speaking, mute, usually that's the answer. And I do have someone do yard work, but I don't think you should. Okay. You might not be, you shouldn't be able to hear him, but you might.
Okay.
I saw the poll close, but I didn't see a result. There, false. Good job. Good. So I'm gonna side with the side of the folks who answered true. And this is a little bit of a tricky question, and I've been caught up on this one too. I know that sometimes Joint Commission, if they see someone wearing gloves in a hallway, they will at a minimum comment about it, and they may even cite a facility for wearing gloves in a hallway. The truth of the matter, though, is that gloves should be worn whenever there may be contact with potentially infectious materials. And so that means, according to the OSHA standard, that gloves must be available if personnel believe that they may have contact with potentially infectious materials, which could happen during a patient transfer. So while personnel may be allowed to wear gloves during transport, maybe even be required according to the OSHA standard, you know, that we may be required to allow them to by the OSHA standard. They also should remain aware of the potential for contamination of the environment, which of course is the Joint Commission's concern if they're, you know, surveying a hospital, if they touch items like elevator buttons while they're wearing gloves. This is just a contact precaution sign that's available on our website. And of course, you know, gloves should be worn according to standard precautions whenever there's anticipated contact with blood or potentially infectious materials. And then according to transmission-based precautions, whenever patients are known or suspected to be infected with an organism that is epidemiologically important. I wanted to mention epidemiologically important organisms because this is an MDRO presentation, and there's really not a list for all of the things that could potentially be epidemiologically important. Your facility should recognize when you're dealing with a novel organism or when there is an organism that could really have a substantial impact on patient outcomes. And of course, gloves are worn to reduce exposure of the hands to heavy environmental contamination, and they must be used appropriately to decrease several of the risks that we'll address on the following slides. So to reduce hand contamination, gloves should be well-fitting. So the picture on the left side is these gloves are kind of loose. When gloves are loose fitting like that, there's a larger surface area, and the gloves themselves are able to pick up more bacteria than when they are well-fitting. And then there is a high likelihood that hands will become contaminated when removing gloves. So we need to really pay attention to how we remove gloves, and the method that's being used in this picture, they are pulling off the glove with one hand, Sliding 2 fingers on the dorsal side of the hand to remove the second glove has been shown to lead to the least amount of contamination during glove removal. Of course, hands should be cleaned immediately after removing gloves, and glove use is not a substitute for hand hygiene. Deb Birdsall did a study in a long-term care facility about what items were most frequently touched when people had gloves and the gloves were contaminated during care. And these items included disinfectant wipes, patient care equipment, and durable medical equipment. And I think we've all experienced those packages of items that are multi-use. Maybe the whole package isn't used up and hands go back in and out of those items. Really a high propensity for those to become contaminated. CDC does not recommend routine double gloving. And the reason we don't recommend double gloving is because you know, the idea that you're going to wear a second glove and then remove that outer glove and your inner glove will not be contaminated is just false. There is a high propensity to contaminate that inner glove. And in a study during Ebola of double gloving, there was one person in the study who had contamination of their hand, even though the inner glove was not contaminated. So random contamination events did happen despite wearing double gloves. Another thing that we don't recommend is disinfecting gloves during the course of care. That is included in the Ebola doffing protocol, but that is, you know, notably during doffing. And there's concern that disinfection of gloves and prolonged wear associated with that might affect glove performance. So pathogens of premise plumbing, we're going to talk about sinks now. And on this, I think I'll ask you just to, maybe we'll open the chat box. Elizabeth, I'm looking for your help on this, but just want you to take a look at these sinks and think about what you see as problems.
Yeah, I think if folks maybe just want to put some answers into the Q&A or the chat if the chat is working for you. So you're getting some patient care supplies in the splash zone. Should not have items near the sink. That's a pretty common reply, Janet.
Yeah, great.
Soap in the middle of the sink, no soap. Supplies near sink in the splash guard, no paper towels over sink. Got some very, very observant people here, Janet.
That's nice. It's nice. So on the first picture, great comments about having supplies near the sink. So this was actually in a clean supply room. And I included that picture because those are IV solutions, you know, so there's a propensity for those IV solutions to become contaminated with aerosols from the sink. Again, in that picture, and I'll use my arrow, I don't know if you can see it, but the paper towel dispenser is right over the sink, but it's also in the splash zone of the sink. So that's a bit of a problem. So we would prefer that there be like a splash guard here and maybe relocate the paper towel dispenser. That's when let's go back to that. Relocate the paper towel dispenser and have a splash guard between the medications. I really like the comments about not having hand soap at the middle sink and no paper towels. Also, it's hard to see in this picture, but this is a very shallow sink. So there was a lot of splashing from that sink, and the faucet is directly over the drain, again, adding to the potential for splashing. Very small countertop has its pros and cons. The pro is you can't put patient care supplies there, and the con is you know, the splashing can go right onto the floor, which is a slip, trip, and fall hazard, not so much a MDRO hazard. And then lastly, the third one, yes, there's just all kinds of patient supplies, bed linen, wound care, tube feeding supplies, all of that within the splash zone of the sink. And that was a sink where there was an outbreak of MDROs, of waterborne pathogens. So sink hygiene, I think you all have that concept. Tell from your answers, but in an intensive care unit, researchers mounted cameras above the hand washing sinks, and I can't remember the duration of the study. I think it may have only been a month, but during the course of the month, only 4% of the behaviors of the sink involved hand washing. 17% involved hand hygiene. So there was use of alcohol-based hand rub occurring at the sink, but 37% of the events at the sink involved medical care. So that includes filling a medication cup, draining an IV bag, cleaning medical items, and then 56 activities involve disposal of nutrients that could promote microbial growth. And that includes things like tube feedings, breast milk, or human waste discarded into the sink. Again, promoting the growth of biofilms. On a positive note, kind of, 4% of the activities involving the sink included cleaning the sink. And that, of course, should be done daily using an EPA registered surface disinfectant. CDC does not recommend routine disinfection of sink drains. Making an attempt to disinfect a sink drain, just being cautious about how the sink is used and making sure that waste is disposed of appropriately. This is unpublished data, and actually it's under review for publication, but this was a finding at one of the hospitals where we were looking at VIM, carbapenem-resistant Pseudomonas aeruginosa, also known as VIM cripa, and where the faucet was the reservoir. We found with this splashing was coming from the drain to the faucet, likely contaminating the faucet. There was a rubber gasket that you can see as dark red in the image that had up to 500,000 colony forming units on the rubber gasket. It was not determined that the rubber gasket was the cause of contamination. It was a nidus of infection is the term that we used. But the faucet could have become contaminated even without the rubber gasket being there. The faucet body core and the faucet valve handle and the supply line had all been contaminated with the organism of interest during that outbreak. Again, we felt that likely came from splashing of the drain up to the faucet. So just a note that can happen. So CDC does recommend that hand washing sinks be included in water management programs. Probably the biggest weakness that we see with water management programs is that they address supply water only, and they don't address wastewater. And so when we think about wastewater, we want to make sure that if it's at all possible, sinks are dedicated to hand hygiene, that personnel have been educated to avoid behaviors that promote nutrient growth in the sink, that countertops are free from patient care supplies. And then again, related to avoiding splashing, we can do some things with water pressure to reduce the water pressure. There's a little bit of a balance there. If you reduce it too much, you can end up with more biofilms. But reducing water pressure can also reduce splashing. And then there are some interventions that we take to help eliminate biofilms related to heating of the water. And there is now an EPA registered disinfectant that has a biofilm claim. There are no protocols for its use, so we don't have any data about how it works and how it may affect healthcare associated infections. And so if you have a suspected or known waterborne pathogen in your facility, CDC would recommend that you collaborate with the state or local public health department to determine those control measures. Finally, monitoring and feedback. Another poll question. Do you believe that the hand hygiene adherence rate reported at your facility are an accurate reflection of practices? Agree or disagree, true or false? You should be able to click the button on this one. That's also very reflective of national data. So in the past, and maybe in the future, I'm not sure, I don't really know the future, but in the past, observation has been held up as the gold standard for collecting hand hygiene data. And a recent study showed that about 58% of healthcare personnel did not find that data to be credible. It's really important for improvement that personnel understand and believe the data that is reported to them. So we all know that the Hawthorne effect is, bias that occurs when people know that they are being observed. And I heard Elaine Larson say just yesterday, it takes about 3 seconds to know someone is watching you, and when people know that they are being observed, they modify their behavior. And sometimes that's just unconsciously done to improve performance. Again, about 58% of personnel did not find observational data to be helpful. The people who were conducting the observations worried that they might miss something, and the people who were being observed worried that their behavior would not be seen. So when direct covert observation is used, healthcare personnel should be educated so that they fully understand facility expectations. And that kind of takes us back to that first, the first few slides. Is it adherent to simply put on gloves, or must you do hand hygiene before you put on gloves? Observers should know exactly what they're observing. I like the way that the WHO phrases it: collecting observations is a complex skill, and all those who collect observations should be trained. Covert observations should be time limited, no more than 15 minutes spent on a unit conducting observations. And if automated data is used, it should be validated. Personnel who are being monitored, and of course it's the behavior being monitored, not the personnel, but often they feel monitored. They deserve to know that the data that's being collected is credible. This leads, this is directly related to the culture of safety. Adherence is lowest when individuals are responsible without the support of their peers. When there's a theoretical risk, someone could get an HAI, but they're not really made aware of the HAIs that are actually happening on their unit, and they don't necessarily understand how those HAIs may be transmitted. When you have a blaming culture, adherence is a little bit improved. So things like giving citations for not doing hand hygiene. People will perform better, at least when they're being watched, but it doesn't lead to really high adherence. When you have a blaming culture, people tend to think that the risk is associated with others, not my behavior, it's others' behaviors. And they are aware of patient safety, but they're not empowered, they're just held accountable. The highest adherence occurs when there's a collaborative environment, and when responsibility to reduce the risk of HAI is collective and it's shared. In that case, People are aware of patient safety events when they happen, and they're empowered to speak up to stop them if they see something that, needs to be stopped. We have several ways of measuring hand hygiene, and I do think direct overt observation, is often not differentiated between direct overt and direct covert, but direct overt observation has an important role to play in improving hand hygiene. So it can be used to evaluate technique, and it's often included in bundle checklists. So if you have a central line checklist and you've included hand hygiene in that checklist, you want to see 100% compliance. You should see 100% compliance. And if compliance is not, in place, then that person is allowed to speak up and correct it. So that is a very a valuable use of overt observation. Overt observation, however, should not be used to calculate adherence rates. People know that they're being watched, and it's just not useful. Covert observation can be used, again, to evaluate technique, but people don't know that they're being watched. So if you don't give them feedback right away, you may not change their behavior. Direct covert observation can also create kind of an ethical dilemma for people if they're watching harm events without speaking up. But it is often used to calculate adherence rates, and depending on the way that it's conducted, they may be credible and they may be an accurate reflection. Automated hand hygiene monitoring systems are more and more available. Some of these systems are very simple in that they just count the number of people who enter the room and the number of times the sanitizer was accessed. They do provide large data sets, but that requires, skill in analyzing that data and conveying results. And then in outpatient areas, the patient can be an observer. This is not feasible and should not be used in inpatient areas because patients are often not able to participate, and because there are many, many more opportunities for hand hygiene. But in an outpatient area, for example, maybe a clinic that the IP oversees that has 2 or 3 people working in it and nobody can come in and do hand hygiene observations. A simple survey asking the patient if hand hygiene was performed before they were touched has been shown to improve patient satisfaction and does provide feedback for individual providers. If you're conducting direct covert observations, how many observations should be collected? We would suggest that you utilize a sampling plan. So you can take a look at all areas and units on a monthly basis. Consider the risks to individuals on the unit. Some of your units, like your NICU, your stem cell unit, they're going to have higher risk individuals, and determine what opportunities are going to be audited. So are you going to audit on entry and exit, or are you going to try and audit all 5 moments? It's not very easy to audit all 5 moments, and adherence seems to be pretty consistent with what you see on entry to exit. And so it has been suggested that entry and exit is a valid time to audit. I do want to point out that, in my personal opinion, I do not favor gel in, gel out instruction. Instruction should include all 5 moments, including the 2 added by CDC immediately following glove removal. But for auditing purposes, watching on entry to exit gives you a direct line of sight and can be an accurate an accurate look at how people are adhering. So units with high-risk patients may need more observations. Any unit undergoing an outbreak would need more observations. And then I wanted to just show you this formula that you could use if you wanted to observe 0.1% of all of the opportunities. So, you look at how many beds there are on the unit, what the occupancy rate is, the number of days in the month, and just a conservative estimate of 30 hand hygiene observations in a 24-hour period. So, and if you count in and out of the room, for hourly rounding, it's easy to see 30 observations per patient in a 24-hour period. So if you had 30 open beds with a 90% occupancy rate in a 30-day month, 30 opportunities per patient, you're looking at 24,300 opportunities during the month. So 0.1% would be 243 observations. That is a lot of observations. And CDC does not say that you must collect that many observations. However, if you want to really say whether hand hygiene is improving, you do need a baseline estimate that has some statistical validity. And that may not be realistic for every unit every month. But it would give you some statistical validity to say that you have improved hand hygiene. This is a quick observation tool that was developed by APIC and CDC. This particular tool is called is the standard precautions tool. I like this tool because of number 1, 2, and 3, 1, 2, 3, and 4, where you're auditing is the sink readily accessible. So in the one picture of the sink that we saw with all of the supplies, the faucet was actually blocked. That would be a no. Are the hand washing supplies available? Is the sink area clean and dry? Are there patient care supplies on the counter within a splash zone of the sink? These can be conducted really quickly, could be done by a champion on the unit, and could help reduce clutter around sinks and ensure that the environment of care supports hand hygiene. Feedback is really important. One of the biggest weaknesses with feedback is when it doesn't penetrate to the front lines, when it makes it just to the infection prevention committee or to senior leaders. Frontline people need to know how they're performing. Unfortunately or fortunately, whichever way you choose to look at that, a Cochrane review showed that feedback is most effective when performance is less than optimal. And that generally means because you have someplace that you're trying to improve to, you have a goal, you have an aspiration. When the person who gives the feedback is a supervisor or a colleague, that can be helpful if you're doing covert observations. If the person conducting observations debriefs the supervisor prior to leaving the unit, that can help that feedback penetrate and can help reduce kind of that moral dilemma of seeing something that may be a harm event. So building in that feedback immediately to the supervisor if you're using covert observations, that can be done while maintaining the observer's privacy. Feedback is most effective when it's provided more than once, when it's verbally and in writing, and when there is a clear target and an action plan to get there. Having those unit-based managers determine their targets and working with them on their action plans can help improve hand hygiene. And with that, I think we will get to questions and answers. Before the question and answer slide, I know there's a whole bunch of slides about CE, so I'm going to turn it back to Elizabeth and see if she would like to do question and answers or.
Yeah, Janet, I think we're at the top of the hour. So maybe we should just go to questions and answers first to make sure we get those done. So one question is, there's a lot of information about skin irritation and dryness, yet what about nails? Drying out the nail beds leads to weed, cracking, splinting nails, yet we discourage nail coverage for good reason. And perhaps we should start discussing nail health as well as speaking about skin. Wanted to see if you had any comments on that.
I think that's an excellent point. When it comes to nail polish, Elaine Larson published a study back in the 90s about the sacred cow of nail polish. So we know that chipped nail polish and old nail polish can be more heavily contaminated. So educating personnel about nail health. The nails should not extend past the fingernail or past the tip of the finger. That's why I said facilities can make their own policies about whether or not to allow nail polish. When gel shellac is used, as it grows out, there can be gap between in the subungual area that makes it a little bit harder to clean. But I really like the suggestion of talking about nail health. Thank you for raising that question. I
Thanks,
see one.
Janet.
Should gloves
yeah,
be
great.
stored in bathrooms? There haven't been too many studies showing glove contamination. I mean, I would think that they should be stored in a clean area. If they're stored in a bathroom, they should be used in the bathroom and discarded in the bathroom, right? You may need some gloves in there if you're going to find yourself assisting someone with toileting and your hands are going to be exposed to, you know, fecal material. So I wouldn't be completely opposed to storing gloves in the bathroom, but I would definitely want to make sure that they're used and discarded in that bathroom. So that's a really good question about COVID testing. We no longer require double gloving, and from the CDC standpoint, we never did require double gloving for COVID testing. The only PPE protocol that includes double gloving is the Ebola high-level PPE protocol. And so no, we would not encourage double gloving for COVID testing. I don't know if there's something different about your protocol. So, I want to give some leniency to a facility, but it would not be a CDC recommendation to go to double glove for COVID testing. If someone is transporting a potentially contaminated item from point A to point B within a facility, should they have both hands gloved or one gloved hand and one clean hand to be able to open doors without contaminating surfaces? I really like that question, and I've seen it done two ways. One is to have one gloved hand and one clean hand. It's kind of hard to have, that means you have to do hand hygiene and put one glove on, which can be a little tricky. The other thing is to have a clean, dirty partner. And either way, but yes, employees should be, healthcare personnel should be educated to avoid environmental contamination when they're transporting dirty items. I see a question in the chat about air hand dryers in the bathroom. And I know that there's a study that shows the propensity to disperse bacteria when jet dryers are used, so they are not recommended. We recommend disposable or single-use towels for hand drying. Leapfrog requires a certain number of observations per census. I appreciate that comment. I'm aware of the Leapfrog requirement. I know that it's really a difficult number to achieve. I think the most important thing is, to get credible data. Your personnel need to be able to believe the data that they're seeing. And I know that, the way that University of North Carolina has done it is very innovative. So yes, I know that that's a ABHR for facilities with memory care residents. So we have at times recommended individual pocket-sized containers. If those are used, they must remain in the control of the healthcare personnel. They should be carried on their body and never left sitting on a countertop anywhere, because an individual pocket-sized dispenser can provide more risk than a wall-mounted dispenser. Because non-alcohol-based hand sanitizers are less effective against certain organisms, particularly gram-negative organisms, we do not make any recommendation about the use of non-alcohol-based hand sanitizers. I have had folks in memory care centers point out to me that you can see someone activating a wall-mounted dispenser, and so they felt like those were pretty low risk. But each individual facility would need to do their risk assessment and really consider the risk to their residents. Again, if they use individual pocket-sized containers, they should remain in the control of the healthcare personnel. And then I guess one last question. Would you recommend doing hand hygiene in between steps when donning and doffing PPE? I would not. Well, we do recommend hand sanitizing before patient contact. And so that's the indication before you put your gloves on. I don't know that I would recommend it, between steps when donning, but I would consider it between steps when doffing. So I know, when doffing, you remove your gloves. And I'm trying to remember it. I haven't done this in a little while, but you need to do hand hygiene between steps when doffing. Thank you, everyone.
Thank you so much, Janet. If you could just advance the slides for the folks that are still on for me, just wanted to highlight that CE is available. And Janet, you can go to the next slide for me. If you all received this flyer when you registered, all the information that you need about CE is actually on this. And if not, you can just reach out to me via the Zoom email that you got for registration, and I can provide it to you. Next slide, Janet. So the little small print shows points number 4 and number 5 are what talk about the CE. So, because you all listen to this live, you fall into this category 4. You just need to hit these links. It's going to take you right to this TICO website where you can complete the post-test in your evaluation. Next slide, Janet. If you've ever, no problem. If you've ever been to TICO or never been to TICO, this is what it looks like. You basically have to register for an account. If you have one, you enter your name and username and password. Next slide. And then just enter the course registration that's in part of that flyer. Next one. But in addition, all of our webinars actually go to this website here. This is the Virginia MDRO Containment Webinar Series. And I just Google Virginia MDRO Webinar Series, and it's the first one that comes up for me. But that also hosts the flyer, and then Janet, next slide, along with all of our webinar recordings, slides, and then information about CE. So even if you have a colleague who didn't listen to this live but wants to go back and look at the webinar and listen to the slides, no, that's totally wrong. Look at the slides, listen to the webinar, you actually can still get CE, and that would be the CE on demand. Next slide. Yep, I think that's it. So thank you, everyone. Really appreciate all your attendance, and looking forward to next month. Where I'll be giving a talk along with some support from Janet on environmental cleaning. I hope you all have a great day, and we'll see you next month. Bye, everyone.